Good morning, everyone who's just joining the webinar. We'll be getting started in just a couple of minutes as everyone logs in. All right, good morning, everyone. My name is Garrett Sheehan. I'm President and CEO of the Greater New Haven Chamber of Commerce and Quinnipiac Chamber of Commerce. We are very pleased to be putting on a webinar this morning presented by our Healthcare and Life Sciences Council, presented by Murtha and Cullina. Really appreciate the council getting together and generating some really good content for us today. Our guest is Dr. Stephen Choi, Chief Quality Officer for Yale New Haven Health and Yale University School of Medicine. Dr. Choi, thank you so much for joining us this morning.
Thanks for having me, Garrett.
Dr. Choi, I know it's been over a month now that you've been on the front lines of dealing with the virus, trying to understand it, and dealing with it from the hospital perspective. Why don't you just start us off, talk a little bit about our understanding of the virus right now and what you're seeing.
Sure. So, even before a month, and it wasn't exactly a month when we had our first case, we've been tracking the spread of this pandemic, and it wasn't even called a pandemic at the time, but I think we knew once we saw cases, certainly the outbreak in Iran and Italy, and then that first case reported in Washington State, which was even before the big outbreak in Iran and Italy, that we knew this was likely a pandemic as opposed to an epidemic isolated in China and the neighboring regions in Asia. So what we first started doing was making sure we had our screening process in place. And that was a challenge. As you can imagine, we have tens of thousands of interactions with patients every single day throughout our health system. So that whether that's, outpatient visits, ED visits, procedures like getting a chest x-ray or an echocardiogram or even an ultrasound for moms. It was difficult trying to get everyone to screen properly for people who had been traveling from what they called, the high endemic areas. But what we've seen in the last few weeks certainly is a rapid acceleration of both cases that have been diagnosed in the state and a number of people who've been admitted with COVID-19 laboratory confirmed infections. Unfortunately, we live right next to the probably what is considered now the largest hot zone in the world right now, and that's New York City. And so we're seeing a lot of the migration from New York, both just the transmission of the disease as well as people just flocking out of New York and then spreading the disease in the neighboring areas. And I think it's important to consider for those of us in Connecticut, while we're not completely, not at risk, it is a different environment from New York City. As you can imagine, with New York City, you've got over 8 million people living in what is a pretty small area. And the housing, demographics of New York allow for this virus to spread pretty rapidly. And so, New York is, has nearly half of all the cases in the United States. And that's not surprising, particularly with the 3 major airports in the area, Queens, Brooklyn, Newark Airport in New Jersey. And then when you think about all the mass commuters coming in from the trains, subway system, taxis, buses, it's really not a surprise that they're the new hot zone or the hotbed. So we're seeing a lot of cases trickling in up through the Bronx, Westchester, and one of our hospitals, Greenwich Hospital, which is just at the border of Eastern Westchester, has seen a large number of cases, particularly this past week. All in all, we have about 150 cases at the Yale Health System. I don't have the update from the Connecticut DPH, but we certainly have the bulk of all the admitted patients in the state of Connecticut right And what I've told all our viewers and our colleagues and certainly my friends is that we should anticipate a pretty big rise in the next couple weeks.
Is there anything unique about how this virus transmits, or is this very similar to cold and flu, how it transmits? I think people have been surprised by just watching the numbers skyrocket over the last few days.
Sure. No, this virus is it's a very, very invasive, elusive, very clever virus, if you will. It can last on surfaces for extended periods of time. There's a lot of studies that suggest that it can last for well over hours. But the primary transmission is really person to person. So if you and I were sitting in a room together within 5-6 feet, you could easily become infected because it's airborne. So if I coughed and sneezed, which is the primary mode of transmission, those tiny microscopic respiratory droplets can land inside your nose, your mouth, and even your eyes, and then you can become infected. So you can imagine if you're in a crowded place socially, or even if you're out working and you've got an infected colleague who doesn't know he or she's infected and start coughing, or that person starts coughing rather, that that could get transmitted in that room. It's not something you can see or smell, and you can easily become infected with the virus. The other means by which you can get infected is if someone coughs on a surface or coughs into their mouth and then touches a surface. Another individual can come in contact with that particular surface, and then if he or she puts their hands on their mouth or nose, then the virus can get transmitted that way as well. And while that's not the most common form of transmission, that is definitely another susceptible means for transmission. And then some of the not so common ways, but we've heard reports about fecal oral transmission. So they've been able to isolate the virus in stool samples. And so whether you're living in an endemic area, or if you're living in a crowded housing community where you can't exercise good hygiene, or you're not being vigilant, that's another means for transmission too, like certainly using bathrooms and public restrooms. And so that's how it spreads so readily. So when you hear about PPE, which is the personal protective equipment that the healthcare workers are having to wear to protect themselves, that's why there's such a large list of items that we have to wear. And that includes a pair of goggles or a face shield with a plastic shield over our eyes. We have to wear a specific filtration mask, or a mask that filters out these microscopic particles. And those are called the N95 masks that everyone's been talking about. And then we also have to wear a gown and a pair of gloves, because we could come in contact with those viruses, as I spoke about, on surfaces. And those viruses could also land on our clothes or our uniforms. And so we have to essentially protect our entire body.
There's a lot of our businesses, some of them that are on the line today, they are still operating, especially a lot of the manufacturers, some of them trying to even make some of that PPE. Just given what you said, how should they try to operate if they have to operate? We're definitely recommending everyone work from home if you can, but how should they try to limit the exposure to anyone that's at their workplace?
Sure, I think the workplace for those essential businesses that are still operating, I think it's critical to try as much as possible maintain social distancing. And I know that's a lot easier said than done. There are going to be some businesses that you just physically can't, but as much as possible, I would try to limit the close contact of employees. And again, the CDC uses a conventional distance of 6 feet. So if that's possible, or to the extent that it's possible, I would try to space those workers within 6 feet. And then I think you also have to be very vigilant about making sure that those employees have access to, hand sanitizers, and if not, make sure that they've got, water and soap available at all times. Some businesses, not all, are actually monitoring temperatures of employees that come in. So, it's hard for individuals to self-detect a low-grade fever, especially a fever that's only 100.5, 100.6. And so some employers are actually checking temperatures as employees come in to make sure that they're not posing a risk for the entire, office or factory or plant or store or restaurant. And then I think you got to be very diligent about wiping and cleaning those surfaces in the building as well every single day. Those are the high touch, high frequency surfaces, like the doorknobs are probably the biggest culprits for spreading this type of virus. Kitchen sinks, the faucet knobs in the kitchen sinks, if you've got one. Certain places will wipe down all their keyboards. We do that here every single day. We come into the call center, we make sure we wipe down our keyboards and our desk surfaces so that we're not transmitting this inadvertently while we're at work. And remember, those are good practices, not just for coronavirus, but other viruses and other bacteria and other, fungus that can lurk inside a workplace. So I think this has been a good exercise of, exercising good hygiene all around, both at the workplace and at home.
And let me just say to everyone that's on the line, if you have questions, you can type them into either the chat box or into the Q&A box, and we'll read those off to Dr. Choi. Actually, Dr. Choi, you mentioned temperature screenings at workplaces. I had a question this morning from one of our manufacturers. If they did decide to put that in place, and they're wondering right now if they should put that in place for their employees, the people who are reading the temperatures, should they wear PPE to protect themselves? What's the kind of best way to go about doing that?
Sure. It's probably a safe practice to have those individuals wear a mask who are taking those temperatures, because it would almost be impossible to take a temperature without being within 6 feet, unless you've got really long arms. But we have the people in our certain areas taking temps. Certainly visitors who are coming in, they're wearing masks to check the temp, and they're wearing gloves in case they come in contact with someone who is in fact febrile or has a fever and may in fact have some symptoms that they're just not recognizing.
What is temperatures on a normal day for someone can vary a little bit, I know. So at what point should someone go, okay, this is an issue here?
Yeah, so the conventional cutoff we're using is 100 degrees. And the reason we're using 100 degrees is, the core temp is usually higher than the, oral, eardrum, or the surface temp. So if you have a surface temp of 100 degrees, chances are that you probably got a core temp that's going to be higher. So we're using a cutoff 100 degrees. Other centers are being a little more liberal, saying 103 or anything above 100.3 is considered fever. But I think if you use 100 degrees, you're pretty safe. That's
good to know. Going back to the personal protective equipment, I know we at the Chamber put out a big call to all of the businesses in the community because the hospital needed more. There's a huge demand for it. Yeah. First, I guess, what are you seeing at the hospital? Are you guys starting to get the equipment you need? Are you in a position where you have enough for now? I mean, we definitely want people to continue to send it over. Yeah, so that is probably the biggest source of concern for healthcare workers and hospitals, particularly our health system. We have nearly 3,000 hospital beds across our health system, and we certainly have capacity to increase that if we need to move into other areas within the hospital that aren't conventionally used for inpatients. But PPE, the personal protective equipment, I just listed all those items. And right now, of those items, the biggest shortages are the masks. Those are both the regular surgical masks,
as well as the N95 respirator masks. And so we're seeing shortages all over the country. And currently we don't have supplies that are going to last us beyond a week or two. So that's a big concern. You know, we're looking for vendors who can increase their production. I know around the country there are a bunch of private and small and large factories that are converting their production away from their usual product and trying to make more masks. The other thing, you know, we should also talk about is ventilators. It's not a personal protective equipment for the healthcare workers, but it's certainly a vital equipment, piece of equipment for our patients. And that's looking like there may be a significant shortage around the country. And you've probably heard all the headlines between General Motors, Tesla. Many of the larger factories are going to start to produce parts for ventilators as well too. So we've got shortages that we anticipate for ventilators as well as PPE. And those are our two biggest constraints in terms of products.
How about on the testing side too? I know there was a big shortage of testing early on. I understand there's still a shortage. Where do you guys, is enough testing occurring right now or a need for much more?
There definitely is not enough testing going on. And it's not as from a lack of interest or wanting to do that from the provider perspective. It's just lack of capability. And the capacity requires both, you know, having enough swabs to take samples, and there's been a, you know, gradual shortage of these swabs that, you know, you insert into a nasal passage and then place in a vial to collect that sample so they can run a what we call a PCR. And the PCR test is where it actually purifies the protein in that swab collected from a patient. We amplify it, meaning we duplicate it, and we test that protein to see if it matches a sample that is equivalent to the coronavirus. And in order for us to do that test, it requires a lot of chemicals, a lot of what we call reagents for that chemical process. And there's been a national shortage of that as well too. And so both the equipment that it requires to collect the samples, as well as all the machinery and the chemicals required to duplicate those tests and amplify that protein in order to diagnose the coronavirus, those are at shortages. So we've had fluctuations in terms of getting the materials, getting the supplies, and then, you know, seeing a shortage because the entire country is you know, in demand for these supplies.
We had a question, and I know we talked about this a little bit at the top, but definitely with New York being such an epicenter, we should expect to see more people coming in from New York. You know, obviously, if you're in the city, a lot of fear that there's not going to be enough hospital beds if you get sick. Just what does that mean for Connecticut, where obviously, you know, just our commuting patterns match up with New York a lot, and what does that mean for our residents in general?
Sure. Well, you know, we're already starting to see, you know, a number of patients in Westchester that are, you know, being seen in our hospitals further south in South Fairfield County. I think it's too hard to say, Garrett, what's going to happen in New York. I know while, you know, they're seeing a big surge, you know, there still seems to be some capacity in New York City within the beds. It's by no means am I saying it's slow. It's not. I know one of their large health systems, you know, already has about 1,300 patients across their 12 hospitals, and they're the biggest provider in New York. And so, we're seeing some of the, I guess, the halo effect spreading into the other communities, and it's not just Connecticut. If you look at New Jersey, you know, New Jersey's seeing a big rise in the number of patients that they're seeing. Same with Queens, Brooklyn, most of Long Island is seeing a big surge as well. So again, you know, my response is these next couple of weeks will tell us a lot about what direction this is going to go.
Just had a question about, you had mentioned cleaning keyboards. How much cleaning do you have to do? What is, you know,
Sure.
How should you do it to make sure you've you've taken care of most of the virus that would be on there.
Yeah, well, if you can get those industry grade wipes, which unfortunately I think they're short of, you can make an alcohol-based wipe. The CDC recommends a 70% alcohol content. It's slightly higher than what we use for hand sanitizers because those surfaces are a little harder to clean. But we just want to do a really nice, thorough wipe down, and you want to get the areas that you're going to be touching a lot. So again, keyboards are, if you're in the workplace, that's one of the most common surface areas that you can get contamination, especially if you're sharing keyboards with various people. But doorknobs and handles, certainly to the bathrooms that people share is a big one. The faucet handles and knobs in those bathrooms or kitchen areas, and other common surfaces that you think people are constantly in contact with. So depending on the business that you work in, the store, the factory, maybe it's a restaurant that's still operational just for delivery and takeout. Just think of all the surface areas that you feel everyone's in contact with. I think it's virtually impossible for a business to do a complete wipe down every single day. I applaud people for trying to do that, but there are many businesses where the square footage it's just too big, and you would quickly run out of wipes or disinfecting products if you were to do that every single day.
Yeah, I think as we've all kind of gone through this, we've been amazed by just when you start really thinking about how many different things you touch, and you can take it really to the nth degree. Just even bringing food back from the grocery store, the boxes that you picked up and
oh
things.
yeah, yep, it's hard.
We were talking a little bit beforehand that the patients you're seeing are not just the old. That was a kind of perception that was out there. This is the elderly, 60 and above, that are really having the most difficulty with the coronavirus, but that's not the case.
Yeah, so I think in general, the U.S. Healthcare systems have seen somewhat healthy 40, 50-year-olds being admitted to their hospitals and also requiring ICU. And we've got patients across the country in that age group that are also going on mechanical ventilation, which is those breathing machines. And that was a surprise and certainly a concern. The overwhelming majority of patients that do get severely ill are still the elderly, but I think this notion that the younger generations are impervious or completely immune to the severe effects of the coronavirus are not true. And I think particularly the younger community in the U.S. who are still unfortunately traveling and having social gatherings and feeling like they'll be invincible, that's a very dangerous assumption to make. And I for the parents that are on the webinar, I urge you to speak to your children, particularly those who are having difficulty, staying at home and want to see their friends, that this virus, is not biased towards older people only. It will attack children, it will attack babies, newborns, and certainly teenagers, adolescents, college-age children as well.
And I know we're still learning a lot about it. We don't fully understand the virus, but what are you seeing as to why one person has no symptoms and is carrying the virus versus someone who has extremely severe reaction to it?
Sure. Again, we're still learning a lot. We do know that there are certain underlying conditions that predispose patients to a more severe disease. And that piece has been consistent in terms of what was originally published in Asia and in Italy, and now what we're seeing in the US. And that's comorbidities like chronic lung disease, so COPD, smokers, diabetes, heart disease. Those all tend to exacerbate this disease. I think the specific mechanism for why those diseases exacerbate this is still not well understood. But what this virus does, it attacks a specific cell in your lungs. It's called a pneumocyte. And these cells line the inside of your lungs. And their primary role is to remove all the debris from your lungs that we inhale. So, every day when we walk out, even, going on a hike, there's a lot of pollen, dust, dirt, particles that are microscopic that, we breathe in. And what these cells do is they get rid of them and they kind of push them up outside of our lungs, and we either cough or we spit or we swallow that, swallow those particles, and then we excrete them through our GI tract. But this virus attacks those cells, and what happens then is the lungs fill up with a lot of debris, a lot of mucus, and then those cells die, and then it causes a massive inflammatory reaction, and essentially your lungs fill up with inflammatory fluid. And so those are the patients that succumb to this disease, where they get acute respiratory distress syndrome, and that's called ARDS. And those are the patients that end up on a mechanical ventilator for weeks and often succumb to the disease afterwards, where they're so sick and their lungs are beyond the point of recovery that they eventually expire.
Just had a question here that came up. Talk of ibuprofen and it not being good for taking in this case.
Sure. So the initial reports, particularly those out of Italy, suggested that if you took ibuprofen, which is it's part of a category of drugs called NSAIDs, and NSAIDs are the Advils, Motrins. Those are the non-steroidal anti-inflammatory drugs. And those drugs were thought to believe to exacerbate patients with certainly moderate or severe disease. And so there was an initial recommendation to not take NSAIDs if you were diagnosed and you're experiencing moderate symptoms. But that recommendation was rescinded because there wasn't enough evidence to say that it actually made it worse. And so if you are having fever, I would recommend starting with something like Tylenol. But if you can't break the fever, we're recommending that you still use Motrin if you need to. So that initial recommendation was retracted by, I believe, the World Health Organization. And I think that was about 10 days ago.
Someone's just asking if you have a factory and you're still working, and then all of a sudden you find out that one of your employees has come down with COVID. What should your next step be as far as taking care of the rest of the workforce?
Sure. That is a fantastic question, Garen. That's a question we face, at the hospital all the time. And so the current recommendation, because it's community transmitted and it's a pandemic, as opposed to an isolated patient or a group of patients in a certain area, it's not practical to do what we call contact tracing, where we look and go back and see exactly who or she was in contact with, simply because the chances of you contracting that illness from that particular individual as opposed to everyone else in the community is now essentially the same. So what you want to do is make sure all your employees screen themselves. And this might be, justification to start doing screening at the workplace, where you check temperatures and then have those employees self-monitor for symptoms. But there's no recommendation that the factory or the store has to shut down and that no one can come to work afterwards.
And you'd probably want to do full cleaning that next day.
Absolutely, or that day.
That day, yeah, as soon as possible. As soon as possible. We were talking a little bit before too. You said there's a lot of innovative therapies and treatments that are in the testing phase, and Yale is a part of those. Yeah,
so there's been a cocktail of medications that Yale, as well as many other acute care hospitals, both academic and private hospitals, are using around the country for COVID patients who are not responding to conventional therapy. And by conventional therapy, I mean really just oxygen, and IV fluids. Sometimes we may have to give them antibiotics if we believe there's a bacterial infection on top of the COVID infection. And so those drugs fall into a number of categories. Number one is the chloroquines or the hydrochloroquines. And if you remember, those are the drugs that people take to as preventive measures for malaria when they travel overseas to those high endemic areas. The second category of drugs are what we call those anti-retrovirals. And the most common retroviral is HIV. And so antiretrovirals targeted initially for HIV is shown to slow down the production of the coronavirus. And then the third is a drug that we initially used for Ebola, which is a different type of virus, but is also thought to decrease the invasiveness of the coronavirus. And then the fourth is it's a monoclonal antibody, and that's engineered to basically target the proteins on the coronavirus itself to again decrease the spread of that virus within a human host. And those are the four therapies that we're using here at Yale. We've got a number of trials that we're about to launch to see how these work. And around the country, a lot of companies are actually looking to do clinical trials as well too. And so, the early reports are all anecdotal. We don't have the traditional randomized controlled trial that we like to use for real scientific literature. But we're using these drugs off-label. As you can imagine, it's not going to be approved by the FDA simply because we don't have the proper trials to do it. But we are using these for patients who are not responding and are getting moderate to severe symptoms.
I had a question here about a mask, and someone was asking how the mask actually works. Obviously it prevents the wearer from inhaling the droplets. Does it also work the other way, where if they have COVID and they're coughing in the mask, that doesn't get out?
Sure. So that's a great question. So the respirator mask, and those are the specific N95 masks, those are intended for a provider, a healthcare worker, a physician, nurse, respiratory therapist, from contracting the virus if they're taking care of a COVID patient. And so those are intended to protect the workers from the infected patients. Prior to getting a patient into a negative pressure room, we'll put a regular mask on that patient so that he or she isn't transmitting the virus. So yes, it can serve both purposes, where you can put a mask on a patient so that he or she, as you can imagine, we talked about respiratory droplets. So if he or she sneezes, the bulk, if not all, of those respiratory droplets are caught inside the mask, and they're prevented from, basically being expelled into the atmosphere where other people can inhale it.
Overall, Connecticut, I think, not right at the start, but we have started to adopt a lot of the social distancing, closed a lot of businesses, had people work from home, schools closed. When will we start to see if that's working, and is that already starting to have an impact?
Yeah, I wish I had the answer, Garrett. That's a tough question, and you heard Dr. Fauci speak on television the other day. The virus will dictate when it's time, and the virus will also be dictated by how we practice social distancing. And if you look at countries like China, South Korea, specific regions like Singapore, Hong Kong, their ability to institute essentially what was quarantining their citizens has really allowed them to see the curve not only flatten, but to actually curve down. And so I think much of this will really depend on how well people are responding and how well people are complying to those restrictions. But I think we all believe at, at a minimum, it's going to be 2-3 months. Thinking that this is going to be over in Easter is wishful thinking, and I think there's some danger to spreading those, speculative opinions, because I think when you start talking like that, then people will not take the importance and the critical nature of social distancing seriously, and we run risk of people, breaking the rules, or kind of cutting the corners and saying, yeah, well, we'll have a small gathering in our house and we won't tell anyone because come Easter, this will all be over. So we're thinking 2-3 months at the earliest.
And there has been a lot of discussion about the second wave. Will this be seasonal, be back in the fall, or, and even I guess the assumption it's going to be better in the summer. We really don't know on a lot of these things. Any insights that you have, or I guess where does the science take us on those types of big questions?
Sure. So, in general, most respiratory viruses do seem to dissipate in the warmer months, and certainly in warmer climates. If you look at the statistics around the globe, it does appear that most of the cases are in the northern hemisphere, certainly over the last few months, which is winter where we live, and not as many cases in the southern hemisphere. But it's not to say that it doesn't exist in the southern hemisphere where it's warm. There's still cases in Africa, cases in Australia, but certainly not the numbers that we're seeing. So I think that could be a possible optimistic glimpse of what we can hope for in the summer. And in summertime too, part of the reason why those viruses aren't as prevalent in the summer is kind of our social practices. There's less commuting within, confined space indoors, because it's cold. Because it's warm, people are outside, and they're getting fresh air. They're out at parks, they're hiking, they're at beaches. But again, this is the scary part about this virus. It'll attack and transmit when you're outside too, if you're in crowded places or if you're in close proximity. But the issue with the second wave, I think we just have to watch what happens in Asia to know if that could happen. I mean, there's numerous reports that China, although they've sort of lifted their social distancing restrictions, they may be seeing that what you referenced, or what the audience member referenced as a second wave, because it only takes one case to then spread it again. And hopefully by then there's enough people that have developed immunity, we call this herd immunity, that there are enough people in the community that have been immune to it, that the second wave won't have as big of an impact as it did during the first wave. But when that wave is going to happen, Garrett, it's too early to say. I think it's much speculation.
Kind of along the same lines, someone asking about, we've heard that we have not seen the peak yet. Obviously, the numbers keep rising. Just explain why there's this expectation that, I've heard different dates for different areas. Some have said, maybe the peak will be in mid-April or early May could be the peak. Where does all that come from? How do we project that out?
Sure. So there are endless number of models out there. I think I probably get 2 or 3 new models every single day in my inbox. And so there's a lot of factors that people use to calculate that. A lot of it has to do with, what's your demographic in a particular region. And I know most people probably thinking, how about the state of Connecticut? The reality is that this virus does not know state borders. Does not know when you're traveling from New York to Connecticut, or if you're traveling from Massachusetts to Connecticut, or Rhode Island to Connecticut. So it's going to spread as if it's one great big region or one big globe. And hence, that's the definition of a pandemic. So we really have no idea of when the peak is going to be to a science, but we make predictions, and part of the prediction is, well, what's your rate of rise in your particular state or region? And I'm going to tell you right now, for those people who are listening, from Connecticut, our rate of rise is continuing to go up. So we don't see a peak coming anytime soon. And when I say soon, I say I don't think we're going to see it in weeks. I think we'll probably see it in a month or months. And we also look at other parameters like, what's the rate of transmission within the community, not necessarily within the hospital, but how many people are getting in the community, right? How quickly is it being contained, or what we call mitigation at this point, like how well are you slowing the virus down? And we want to be able to slow it so that there are enough people that are immune, or the virus just can't survive as well in that community because it doesn't have enough hosts. And the ones that it has infected, those hosts eventually recover and then hopefully develop, a short or long-term immunity to that virus. But if you're asking me when it's going to peak, I don't think anytime soon.
And when we see those numbers reported out each day, is that a laggard of what's happened? So is it that we're just getting more testing online right now, or is there a lot of spread that's occurring right now as we speak?
Yes and yes. The restrictions and the limitations of testing provide a skewed impression and proxy of how many patients are actually infected. It's very different than what South Korea did. South Korea was able to test, approximately 10,000 patients a day, residents a day, and they didn't just test residents that were symptomatic. They just started testing everyone because they were focused on containment. And so is Singapore and Hong Kong. They wanted to contain the virus, and all three of those areas, South Korea being a country, they did a fantastic job, in large part because they had extensive testing capabilities. But we're very slow to the game when it came to testing. We still are. We're not anywhere where we want to be or where we should be. So yes, it's not a good estimate of how many patients are actually infected. It's directional, meaning as you see it go up, you can probably assume that there's probably 10, 100 times as many people that are actually infected. And those people who aren't tested probably don't have severe symptoms to know that they're even infected with COVID, right? You have to remember, 80% of people with COVID will recover without any additional medical therapy, will have mild and maybe moderate symptoms. So they may have a slight cold, they may have what they feel like, oh, this is an allergy, and it may just last a few days and recover and never even call their doctor. So they may just recover and not even ask the doctor. And then two, they may actually be sick, but not sick enough to get tested. And again, we have limited testing around the country, let alone the state of Connecticut. So it's not a great measure, but it's certainly directional, and that's the best estimate that we can use right now.
Starting to get a few more questions here. So as we get close on time, I'll just have you rapid fire on these, Dr. Choi. So should healthy people wear masks and gloves to protect themselves?
That's a tough question. CDC does not recommend that, and I think that's a personal choice. I personally, as a physician, I do not wear a mask and gloves, unless I'm going to, a specific patient care area, and I don't work in patient care. My colleagues do, but it really is a personal choice. The masks that you're going to get online, they're not going to protect you from coronavirus. You have to wear regulated N95 masks, and so those are highly regulated by the FDA, CDC, to make sure they properly filter those microscopic particles, and they also have to have a proper filter around your face so that there's a seal from outside the mask, into your nose or mouth.
Lots of questions about the masks. If someone's wearing one of those N95 masks and the virus is on the outside, and I'm trying to understand this question here, but if it's on the outside of the mask and then they cough, can they refire it off into the air?
That's a great question. I guess theoretically, if it's soiled, right, where you've got, someone coughing during a procedure that involves the airway, and they cough and you see something that soil. Theoretically, I think you can, but those are designed to actually just contain the virus on the surface and not repel them off. They're made of a almost like a paper cloth material, so it does actually absorb those respiratory droplets on the surface.
How long does the virus stay on the surface? I know you talked about that briefly before.
Yeah, so it depends on what kind of surface it is, but the reports range anywhere from minutes to hours. Some reports have said days, but I think the scientific community is taking the position that we really don't know, and even the CDC has said it's too early to say. The reports haven't been validated across each other, but we do know that it can last for hours for sure.
Question about immunity. Do people have immunity once they've had the virus? And also along the same lines, have we started to see mutations in it?
Yeah, so I know at least 2 strains have been identified, suggesting that there may have been a mutation. We do believe people have had immunity to it and are resistant to getting infected again. And I think much of that data is coming from China. And even in China, what they've done, and some centers are trialing here, I believe it's UPenn, my former alma mater, they're actually taking plasma from recovered patients. So that's the part of your blood that contains antibodies. So they're taking plasma from patients who've recovered and then infusing that plasma back into patients who are still very sick, not responding to those medications I talked about, not being able to come off those breathing machines, and transfusing it back to those patients with the theoretic aim that those recovered antibodies from those patients who recovered are helping these sick patients from fighting the virus. Again, no clear clinical trials to demonstrate that it works or if it doesn't work, but the theory is that once you've had it, you've recovered, that your antibodies should protect you from that virus attacking you again and you becoming another infected host. But these are great questions. I mean, these are questions that our medical community has too. So I think you've got a smart audience today.
Yeah, no, we definitely do. Just a couple more. If we do, let's say we hit peak in the next several months, still short of a vaccine, do you see us going into a testing mode where, even after we've reached that peak, we do lots of testing to try to get back into that containment mode?
Yeah, I think, if you speak to my colleagues at the public health school at Yale, one of the best public health programs in the world, this is a nightmare for them. This is what they live for. This is their aha moment. And the fact that they can't administer testing and we can't as a nation administer testing on a large scale is devastating for so many reasons, the least of which is we haven't been able to contain the virus successfully. So I think if it becomes available, our epidemiologists, our public health officials would love to test as many people as possible to understand what is the natural nature of this virus, because what we're going off of, what we're making decisions and pivoting to sort of critical modeling decisions is based on a very small percentage of patients and residents in the community that can actually get tested. So yeah, I think if we have those testing capabilities, we'd love to test a whole lot more.
And let me wrap it up on this one, Dr. Choi, and knowing we don't have that full testing right now, if someone does feel sick at home, what should they do? Should they try to be going to the hospital to get testing, or should they just take care of themselves if they are not in a serious situation as far as their health? Sure.
So this is a great question. I'm glad you asked this, because a lot of people are under the understanding that we don't want to see you, and that's not it. We don't want you to come in if you're potentially infected into the hospitals. And we also don't want you to come in because there may be infected people at the hospital, particularly in emergency rooms. with COVID and other illnesses that are contagious. So what we want to do is have you call your doctor to make sure that you're getting the proper advice, the guidance, and the recommendations. And again, the large majority of patients who get COVID will recover, many of whom won't even realize they had COVID. So what we want to do is make sure that you speak to your physicians, not show up at your physician's office, again, for the risk of cross-contamination, but to contact your physician, because a lot of what we can do in terms of giving guidance and doing evaluation, we can do on the phone. And Garrett's daughter just walked in. That's awesome.
They usually come in by the end.
Yeah. So good things this isn't CNN. She's making faces at you. So much of what patients need to hear is that, as long as you can eat and drink, and as long as you're not having real difficulty breathing, you don't need to come into the hospital. And what a lot of physicians have done is they've also ordered what we call pulse ox machines, or pulse oximetry, and those are the machines, they use a wavelength, infrared wavelength to measure your oxygen saturation in your blood. And if you can have one of those delivered, if you really are developing shortness of breath, that's a way for a physician to say, you know what, I think it's time for you to have to come into the hospital. Because, again, anywhere from 10 to 20% of patients will require hospitalization, and then you'll have to come in to be treated. So yeah, we're not saying don't call us, we don't want to talk to you, you're on your own. We're saying we can give you much of the guidance via phone. And a lot of doctors have what you and I are doing, Garrett, which is teleconferencing with their patients.
Dr. Choi, thank you so much for joining us today. We really appreciate you taking the time and appreciate everything that you're doing on the front lines of this virus.
Thank you so much, Garrett. And thanks to the audience for tuning in.
All right, and thank you again to everyone. Thank you to our Healthcare and Life Sciences Council presented by Murtha, Cullina, for helping us put this on today. Thanks again, everyone. Stay safe and have a good weekend.